but he persisted with ankle pain and the pain abdomen. He was then referred to a psychiatrist. And for 3 years, man went on from one place to the other. Then ultimately, he came to Saptajang Hospital at that time, and he had his serum calcium levels done, and skeletal survey was done at that time. And we found that the man was suffering from actually a parathyroid tumor. And he underwent surgery for parathyroid tumor and got well. So I think as a surgeon, we must be aware of the manifestations of parathyroid tumors and especially look for it. So today we have with us Dr. Manika Arora from Vedanta Hospital, Delhi, and the session will be moderated by Dr. Deepak Sareen. Welcome, Dr. Deepak Sareen. And the topic is clinical features, workup and management of parathyroid tumors. Over to Dr. Manika.
Good morning, everyone. So today my topic of presentation is clinical features, workup and management of parathyroid tumors. Sorry. So coming to the introduction part, Sir Richard Owen is generally acknowledged as being to first describe the existence of parathyroid glands in 1852. There are two pairs of parathyroid glands measured 30 to 50 milligram. Capillate pairs, they arise from fourth brachial cleft and fourth brachial pouch, and they are close to the point of inferior thyroid artery, and they are located over the posterior surface of thyroid gland. Caudal glands, they arise from the third brachial pouch, and they lie over the lower thyroid gland pole. Caudal glands are more variably placed and may found within the pericardium or mediastinum consequent upon the co-migration with the thymus, as thymus is also dweller from the third brachial pouch along with the caudal inferior parathyroid glands. So this is the embryology. As we can see from the third pharyngeal pouch, there is a development of the inferior parathyroid gland along with the thymus, and from the fourth brachial pouch, there is a development of the superior parathyroid gland. Coming to the vascular supply, the parathyroid glands, they have a vascular supply from the inferior thyroid artery, and coming to in relation to the recurrent laryngeal nerve, we have a coronal plane of recurrent laryngeal nerve in this diagram. With respect to the coronal plane of recurrent laryngeal nerve, the superior parathyroid glands, they lie dorsal or posterior to the recurrent laryngeal nerve, while the inferior parathyroid glands, they lie ventral or anterior to the coronal plane of recurrent laryngeal nerve. Then coming to the probable areas of the parathyroid, the superior parathyroids, they are found along the posterior aspect of a superior pole of a thyroid lobe near the tubercle of Zucker candle between the level of cricoid and thyroid. Less common, they are in the retropharyngeal and carotid sheath, while the inferior parathyroid glands are most commonly found within the 1 centimeter of thyroid gland along the lower pole, have more variable position of the inferior glands ranging from angle of mandible to the pericardium area. Coming to the physiology of the parathyroid hormone. Parathyroid hormone, it is imperative for the calcium hemostasis, and it is regulated by the feedback mechanism. If there is a low calcium level in the body, then the calcium sensing receptors which are present on the parathyroid chief cells, they are basically the G protein coupled receptors. They get activated and they sense the extracellular calcium concentration. If it's low, then the PTH level is going to be increased in the body once the calcium sensing receptors gets activated. So this is the physiology of the parathyroid hormone. Parathyroid hormone, it acts basically on the three main organs, that is on the bones. It helps in the absorption of the calcium, thus increasing the calcium level in the blood. Acts on the kidney. In kidney, it is responsible for the reabsorption of calcium and increase calcitriol formation from the vitamin D. in the kidneys, and in intestine there is a calcium absorption. Thus all of the three organs plays a major role in increasing the calcium level in the blood. So as I told earlier, when there is a low concentration of calcium in the blood, there is a release of the PTH hormone via the calcium sensing receptors on the parathyroid surface, and they act on the three main organs, which causes increased concentration of the calcium in the blood. And when the blood calcium rises, the parathyroid gland stopped to release the PTH. This is the normal physiology of the parathyroid hormone. Then coming to the hyperparathyroidism, most common pathological condition affecting the parathyroid glands, classified into the primary, secondary, and the tertiary form. Disorders of parathyroid secretion: primary hyperparathyroidism, secondary hyperparathyroidism, tertiary hyperparathyroidism, and the familial one. Coming to the primary hyperparathyroidism, PHPT, it is defined as hypercalcemia with increased or inappropriately normal plasma of parathyroid hormone. So in PHPT, we have high calcium, high parathyroid hormone, high urinary calcium, and low phosphorus. Because PTH helps in the excretion of the phosphorus, and there is an increased level of the calcium. Thus, there is a high calcium and the low phosphorus in PHPT. And calcium creatinine clearance ratio, it is more than 0.02 in PHPT, while it is low in FHH. PHPT is a common endocrine disorder, usually discovered by routine biochemical screening. Most common clinical presentation of PHPT is asymptomatic hypercalcemia. Findings of elevated PTH with hypercalcemia must be evident on two occasions, at least 2 weeks apart. Excess PTH, it is produced by neoplastic or hyperplastic growth of parathyroid parenchymal cells, that is adenoma or hyperplasia, seen in the older patients, 5th and the 6th decade, common in females as compared to males, and usually it is a single adenoma in 85% of the cases, and in 15% of the cases it's multiple gland disease. And when the PTH is only minimally elevated or within the normal range, PHPT remains the most likely diagnosis, although FHH is also possible. Coming to the etiology and pathogenesis of PHPT, parathyroid adenomas are monoclonal or oligoclonal neoplasms, that is a clonal expansion of cells that have an altered sensitivity to calcium. Genetic rearrangements of cyclin D1 gene have been identified. Somatic mutations in both gene copies of MEN1 tumor suppressor gene are also seen in 20% of the patients with primary hyperparathyroidism, and FHH and neonatal severe hyperparathyroidism. And these point mutations are seen in the CASR gene, calcium sensing receptor gene. Then this is a parathyroid adenoma in which there is a clonal expansion only in the one of the parathyroid gland, and it is a hyperplasia of all of the parathyroid glands. Is it not all hypercalcemia is PHPT? There are the other causes which are important to rule out the hypercalcemia. So causes of hypercalcemia, primarily it is a primary hyperparathyroidism, which is a parathyroid mediated. Other inherited variants are MEN syndromes, that is MEN1 and MEN2A, FHH, and tertiary hyperparathyroidism. Then coming to non-parathyroid mediated, in which hypercalcemia is seen, there is a hypercalcemia of malignancy, vitamin D intoxication, and chronic granulomatous disorders, in which the parathyroid hormone related peptide plays a very important role in the hypercalcemia. Then coming to the medications, there are thiazide diuretics, lithium, and excessive vitamin A in the theophylline toxicity causes hypercalcemia. Coming to the clinical presentations, they are stones, bones, groans, psychic moans, which are fatigue, depression, anxiety, and the constipation. So again, I'm going to describe the pathophysiology of the parathyroid hormone, which plays an important role in the clinical presentation, where we have osteoporosis, osteopenia. So when the PTH hormone acts on the bone, it causes efflux of calcium from the bone, which and the excessive calcium causes the osteoporosis, osteopenia, and the osteofracture. Because there is a efflux of calcium from the bone, thus it causes osteoporosis and osteopenia and increased susceptibility to the fractures. And when it acts on the kidney, there is a increased reabsorption of the calcium, which causes decreased loss of calcium in the urine. Thus, there is a presentation of the renal stones, and thus there is a pain. And when it acts on the intestine, it causes enhanced absorption of calcium from the intestine, causing the nausea and the vomiting presentation. Then renal stones are the major complication of PHPT. Stones are mostly calcium oxalate. History of the broken bones is there in the clinical presentation if symptomatic. According to WHO score, T score of less than 2.5, it is considered as osteoporotic. Then radiographic signs of PHPT includes a salt and pepper pattern, distal clavicle tapering, subperiosteal bone resorptions. Together, these features are described as osteitis fibrosa cystica and are rarely seen in the developed countries, where more subtle forms of skeletal involvement are observed. So this is the typical salt and pepper skull involvement in primary hyperparathyroidism. The lytic lesions, they refer to as a paper appearance, and the sclerotic lesions, they are the salt one. Then the lytic lesions in the metacarpals of the right hand or of the left hand. Sorry. Then coming to the bone dentistometry, in this there is a T score up to zero point 0.1, it is normal, and in between zero point 0.1, -1 to -2.5, it is osteopenia, and if it is below 2.5, then it is known as the osteoporosis. Coming to the normocalcemic PHPT. Normocalcemic PHPT, it is a variant of PHPT. It is an nascent form of hyperparathyroidism. Patients with normocalcemic PHPT typically come to medical attention in the setting of an evaluation for low bone mineral density, during which PTH levels are drawn and found to be elevated in absence of hypercalcemia. It should be under regular monitoring for the progression of disease, with surgery considered for the development of symptoms. In order to make a diagnosis of normocalcemic PHPT, the calcium level should be consistently normal in presence of elevated levels of parathyroid PTH, and all secondary causes for hyperparathyroidism must be ruled out. Coming to the secondary hyperparathyroidism, the biochemical influences causing the chronic parathyroid stimulation leading to hyperplasia, and in this there is a high PTH along with the low or the normal calcium. Causes of secondary hyperparathyroidism, they are chronic kidney disease in which the impaired calcitriol production is there, hyperphosphatemia and hypocalcemia, decreased calcium intake, calcium malabsorption, renal calcium loss, in which the loop diuretics are there, and use of the anti-absorptive drugs, bisphosphonates and denosumab, which causes the secondary hyperparathyroidism. There is an inhibition of the osteoclastic activity, um, due to which the hyperparathyroidism is there. Then coming to the tertiary hyperparathyroidism, in chronic secondary hyperparathyroidism, the growth of hyperplastic gland, it may become autonomous due to the resetting of the calcium receptor on the individual parathyroid cells, and the glands remain hyperplastic even after the chronic stimulus has been removed, and they're mostly seen in the chronic kidney disease patients. Coming to the brief of the primary, secondary, and the tertiary hyperparathyroidism. So in primary hyperparathyroidism, there is a hyperfunctioning of the parathyroid cells itself. Either it's due to hyperplasia, adenoma, or the carcinoma. Secondary, in which there is a physiological stimulation of parathyroid in response to the hypocalcemia. And in tertiary, again, the following long-term physiological stimulation is there in response to the hypocalcemia, which leads to the hyperplasia. So association of the primary hypothyroidism, it may associated with the familial syndrome, that is a men syndromes, men 1 and men 2A. In secondary hyperparathyroidism, it is usually due to the chronic renal failure or other causes of vitamin D deficiency. And in tertiary hyperparathyroidism, it is seen in the chronic renal failure. Then coming to the primary hyperparathyroidism, in primary hyperparathyroidism, the serum calcium in primary hyperparathyroidism, the serum calcium is high and the serum phosphate is low, or either it's normal. In secondary hyperparathyroidism, the serum calcium is low or normal and phosphate is high. And in tertiary, both calcium and phosphate is high. Then coming to the familial hyperparathyroidism, in this we have the bundle of diseases. Men 1 syndrome, which is autosomal dominant condition and occurs due to menin gene. Men2A, it is a autosomal dominant condition, occurs due to the red mutation. FHH, this is familial hypercalcemic hypocalciuria. NSHPT, neonatal severe hyperparathyroidism. ADMH, autosomal dominant mild hyperparathyroidism. Then coming to the hyperparathyroidism jaw syndrome and hyperparathyroidism familial isolated syndrome. Yeah, in Men1 syndrome, it is also known as the Wormer syndrome, and it's due to the menin gene. It's an autosomal dominant condition, and in this, there is a pituitary adenomas, parathyroid tumors, and the pancreatic tumors, which are insulinomas and the gastrinomas. In Men2A, which is known as the Sickle syndrome, occurs due to the red mutation on the chromosome number 11 and 13, and in this, the hyperparathyroidism is there. Medullary thyroid cancer is there, and the pheochromocytoma is there. Then coming to FHH, it's autosomal dominant disorder. There is abnormalities in the calcium sensing receptor, lifelong hypercalcemia with 100% penetrance. There is a calcium in the PTH level which is high, and the 24-hour urinary calcium will be low in FHH. That is a differentiating point from the primary hyperparathyroidism, and the ratio of calcium and creatinine that is less than 0.01. And then coming to neonatal severe hyperparathyroidism, it is a homozygous form of FHH. It is present at birth or within 6 months of life. There is a severe symptomatic hypercalcemia, and the skeletal manifestations are there. Then coming to the hyperparathyroidism jaw tumor syndrome, there is an autosomal dominant tumor gene which is responsible for the syndrome, and the most common manifestation is the parathyroid tumor, along with the association of maxillary fibromas, renal cysts, and hematomas. Then coming to autosomal dominant mild hyperparathyroidism, it is associated with the CSR gene, and there is a hypercalcemia and hypercalciuria. So there is a paper by Khan et al. In 2017 in which the overall incidence and prevalence was described in US, Canada, and Europe of the primary hyperparathyroidism and related clinical presentations. So in India, there is a presentation of a asymptomatic disease, and the predominant presenting features are skeletal and the renal complications. Then coming to the diagnosis, workup, that is workup and the preoperative evaluation, the combination of hypercalcemia and an elevated or inappropriately normal parathyroid PTH level makes PHPT the most likely diagnosis. Serum calcium, a single elevated serum calcium concentration, and the serum PTH should be measured concomitantly with the serum calcium level. 24 hours urinary calcium, there is a measurement of 24 hours urinary calcium excretion that is not always required for the diagnosis of PHPT, but it is routinely measured in the patients with asymptomatic PHPT in order to assess the risk of kidney complications when the urine calcium is high and thus determine the subsequent management. So, for patients with hypercalcemia and PTH that is only minimally elevated or inappropriately normal, given the patient's hypercalcemia, the 24-hour urinary calcium may also help to distinguish PHPT from FHH. An elevated urinary calcium concentration that is more than 200 to 300 milligram per day suggests the underlying PHPT rather than FHH. In FHH, it is low. And approximately 75% of the affected persons with FHH excrete less than 100 milligram of calcium in urine daily. Coming to the flow chart describing the diagnosis of primary hyperparathyroidism. So we are going to measure the intact PTH level and the calcium level. If the PTH level is elevated with a persistent hypercalcemia, then the primary hyperthyroidism is the likely diagnosis. But if the PTH level is not elevated or minimally elevated or in the mid or upper normal range, then again likely it is a primary hyperparathyroidism, but we can also consider the FHH. And if the PTH is not high and it's low, less than 20, and then there we can evaluate. We should evaluate for the known parathyroid mediated causes of hypercalcemia as the PTH is low. We must rule out the hypercalcemia of malignancies and the granulomatous disorders and hyperthyroidism. Then coming to the serum 25 hydroxyvitamin D, there is a measurement of vitamin D metabolites which may be useful to distinguish PHPT from other conditions. Differentiation of family fetches from mild primary hyperparathyroidism with concomitant vitamin D deficiency in individuals and with elevated serum pH and calcium, but with a normal or low 24-hour urinary calcium excretion that is seen in FHH. Coming to the flow chart, in between the asymptomatic primary hyperparathyroidism and the familial hypocalciuric hypercalcemia. There is a 24 hours urinary calcium excretion, and there is a measurement for the serum 25 hydroxyvitamin D. If the urinary calcium is in the upper range of normal or elevated, that is if the calcium excretion in the urine is more than 200 to 300 milligram per day, and the calcium creatinine is high, that is more than 0.02, then likely it is a diagnosis, likely there is a primary hyperparathyroidism. But if both are low, calcium creatinine and if the calcium creatinine is low and the urinary calcium is also low, then we must rule out the FHH. Other tests which may provide useful clinical information, it includes the following: serum phosphorus. The serum phosphorus concentration may be decreased, but typically it is in the lower range of normal. And the markers of bone turnover, biochemical markers of bone turnover like osteocalcin, bone-specific ALPs, are often at the upper end of normal or mildly elevated in asymptomatic PHPT. Coming to the role of genetic testing, the majority of the patients with PHPT don't require genetic testing due to the difficulty of differentiating FHH from PHPT when the calcium creatinine ratio is between 0.01 and 0.02. Some experts have suggested the CSR mutation analysis for such individuals, and it should be performed in the selected patients in whom a familial form of PHPT is suspected, including the young patients with a family history of PHPT, and a clinical finding suspicious for a syndromic PHPT, that is for the men 1 and men 2A, as I already described. When coming to the localization, once a clear diagnosis is made and a patient is deemed an appropriate surgical candidate, efforts are made to localize the abnormal gland. So there are the two ways of localization. Either it's a non-invasive and the invasive one. Non-invasive is ultrasound, technetium 99 system MB scan, CT scan, MRI, and the PET CT scan. In coming to the invasive localization, in this we have the FNEC and the venous sampling technique. Then coming to ultrasound neck ultrasound, it is a useful adjunct to system AB. It is helpful in finding abnormal parathyroid glands preoperatively and has added benefit of identifying coexisting thyroid pathology. It is operator dependent. Adenomas appear as an oval or hypoechoic lesion, usually inferior or posterior to the thyroid. There is a peripheral rim of vascularity sign in ultrasound neck. Due to the vascularity of the thyroid artery, which supplies the parathyroid on the periphery. And the ultrasound neck technique, it is inexpensive, decreases the radiation exposure as compared to CT and the PET CT technique. It's not very helpful for ectopics, and there is a sensitivity of 70 to 80%. So this is the imaging for the ultrasound neck showing the left inferior parathyroid gland, enlargement of the left inferior parathyroid. Coming to the system AB nuclear scan, it's the most accurate, commonly used for localization preoperatively. System AB, it is a lipophilic cation that accumulates in the mitochondria, more in the metabolically active parathyroids. There is a differential washout from the thyroid and parathyroid as compared. Sensitivity is 77 to 89% and specificity is 90 to 92%. Addition of SPECT increases the sensitivity of test in smaller adenomas, and the double phase method is used, in which there is a technetium is used most commonly, and the images are done at 10 minutes and at 2 hours, and we're going to compare the washout from the thyroid and parathyroid. Hyperplastic and adenomatous glands, they are going to be more prevalent at a 2-hour period, and this system will be scanned. It's not helpful for multi-gland hyperplasia. Of course, there is a radiation exposure. False positivity is another limitation. If there is any lymph node or the thyroid nodule. Then there is a activity is prevalent for those also. Thus, there is a role of hybrid imaging, which offers the possibility of functional and the anatomical information. SPECT CT provides a 3D picture that's a better sensitivity as compared to the system AB. So this is a system AB scan at the 2 hours. This is a physiological uptake for the salivary glands and right inferior parathyroid adenoma. Activity is more prevalent for the right inferior parathyroid adenoma at the end of 2 hours. Then coming to the system AB, that is a SPECT CT. We have a case of primary hyperparathyroidism, 26 years female Mrs. Misha, in which there is incidentally detected hypercalcemia during the workup for the wrist pain, and these are the imaging subsequently. There's a SPECT CT, which reveals the left inferior parathyroid adenoma. Then coming to the fluorocholine PET CT, in this the 18-fluorocholine dye is used, which is injected intravenously. Better spatial resolutions, detection of a smaller adenomas are there, and there is a reduced there is a reduced scanning time via the rapid kinetics of the choline, and sensitivity is 90 to 92%, specificity is 100% as per the Lazik et al. Paper in 2018. Through Michael et al. Reported the fluorocholine PET CT as a promising diagnostic technique in 2018. Then this is a imaging from a patient with the multiple parathyroid hyperplasia, one with a slightly ectopic localization, and ultrasound. This is ultrasound imaging. Misdiagnosed this lesion as a thyroid nodule. As uh, as we can see as in a dotted circle. Then this is the axial CT pictography, and in C, in figure C, there is no abnormal tracer uptake was observed on a system B SPECT CT image as described by the hollow arrow. And then coming to the D image, the lesion is well delineated on the MIP image, that is the maximal intensity image of the fluorocholine PET, which describes the probably the right inferior parathyroid, and there is another ectopic present in the mediastinum. Then this is the fusion image of the PET CT, and again there is a fusion of the PET CT image. The hollow arrow, it describes lesion in the mediastinum, and the solid arrow, it describes lesion in the inferior right inferior side. Then coming to the 4-dimensional CT, the fourth dimension is the time. There is accurate localization of parathyroid adenomas prior to the surgery. So in this we have the 4 phases: pre-contrast, arterial, early delayed, and the late delayed phases. As I told, 4 dimension is the time. So each phase is divided in the seconds, and there is a low attenuation on the pre-contrast phase. Maximal contrast enhancement is there during the arterial phase. Rapid washout is present during the delayed phase, and there is a sensitivity of 60 to 87% in localizing adenoma. It's operator dependent, and correct technique should be used for the 4-dimensional CT. So these are the 4 phases as I mentioned in the 4D CT. This is the pre-contrast phase, arterial phase which lasts for 30 seconds, venous phase which lasts for 60 seconds, and the delayed phase which lasts for 90 seconds. And the arterial phase, we can see from A to D figures, there is a there is a suspiciousity for the left inferior parathyroid. And while from figure E to H in arterial phase, there is an enhancement in the right side inferior adenoma. Coming to the selective venous sampling, it is an invasive technique. Angiogram is used, and then the femoral vein catheterization is done, and the collection of blood samples are there from the draining vein of a thyroid plexus. That's from the IGV, brachiocephalic, and the subclavian, and the plot of venous PTH from where the blood samples are collected. Plot is tabulated, and a comparison is done with the baseline, and the ratio of 2 or greater is seen. That is the positive result. So it is useful in identifying the site of abnormal gland, but as it is a time consuming, expensive, and there is a risk of infection, so we are not using it much in the presently. Then coming to the intraoperative localization. Intraoperative localization we can do by the gamma probe. Gamma probe, it is useful for both gland ectopia and the hyperplasia, and it was first described in 1995. And then we can have another techniques, methylene blue injection, and the indocyanine G and the infrared technique. Technique is also used for the intraoperative localization of the parathyroid. Coming to the management of the hyperparathyroidism. So once a diagnosis of PHPT has been made biochemically, a decision regarding the surgical intervention versus observation must be made. That decision varies depending on whether the patient is symptomatic, asymptomatic, or as a familial disease. First of all, we can try the medical management. Can be offered to the asymptomatic patients. Drugs like calcium emetics, bisphosphonates can be used. Maintain the good hydration and avoid thiazide diuretics. Then the surgery, it is curative. And surgery for parathyroidectomy, we have the two options in the surgical part for the parathyroidectomy. It's a focused single gland parathyroidectomy and the four gland exploration. So guidelines for surgery in asymptomatic hyperparathyroidism, age younger than 50 years, calcium greater than 1 milligram per deciliter above upper limit of a normal range of calcium, DEXA score, in which there is a T-score of less than 2.5 in the lumbar spine, femoral neck or the distal radius. Vertebral fracture on imaging is present, and the kidney stones or nephrocalcinosis on imaging is there. Calculated creatinine clearance, it should be less than 60 ml per minute, and 24 hours urinary calcium is greater than 400 milligram per day, and increased stone risk on stone analysis. This is for asymptomatic hyperparathyroidism. Then coming for the indications in symptomatic, again the age is less than 50 years, calcium is more than 1 milligram per deciliter above the upper limit of normal, nephrolithiasis and the nephrocalcinosis, hypercalciuria. There is a 24 hours our urinary calcium level is more than 400 milligram per deciliter, impaired renal function. There is a GFR rate is less than 60 ml per minute, and wound density score is less than 2.5, increased risk of fractures and the vertebral compression fracture, pancreatitis, peptic ulcer disease, and the gastroesophageal reflux, and the symptomatic PHPT, and the muscle weakness and the sleep abnormality. Then coming to the focused parathyroid exploration, focused parathyroidectomy is ideally employed in a patients who appear clinically and by imaging to have a single parathyroid adenoma. It's not recommended for the patients with non or suspected multi-gland disease. This approach is appropriate for patients with unequivocal imaging suggesting unilateral pathology. There is no family history of men's syndromes, and no suggestion of concomitant thyroid disease requiring surgical intervention for the focused parathyroid exploration, and it should be approached like thyroidectomy. There is a horizontal skin excision below the cricoid, subplasmal flaps should be elevated and the straps retraction are there. Exposure of thyroid is there, and it should be retracted immediately, and then we must look for the parathyroid gland which is suspicious. So normal parathyroid glands are 5 to 6 mm in size and weight is 45 to 50 milligram. They're soft caramel color, and care should be taken not to rupture the gland. So this is showing the left superior parathyroid adenoma, and in this there is a large left inferior parathyroid adenoma intraoperative. Parathyroid, there is a need to differentiate it from the fat, lymph node, and thyroid. As in this picture, A is describing the lymph node, B is a parathyroid gland by its color, and C is a fat locule. Intraoperative parathyroid hormone measurement. It's a useful adjunct to determine the success of surgery, mainly used in a single gland disease. Half-life of PTH is 3 to 5 minutes. Rapid PTH assay is available to confirm the removal of correct adenoma. Using the Miami criteria, there is a 50% drop in PTH, and surgeon excises the hyperfunctioning adenoma. Intraoperative parathyroid hormone monitoring guided has become the preferred approach nowadays. So this is the Miami criteria, in which there is a 50% PTH drop from either the pre-incision or the baseline or the pre-excision at 10 minutes after the excision of the parathyroid gland, and there is a accuracy of 97% and the positive predictive value of 99.6%. And there are the other criteria also: Vienna, Rome, and the Hall criteria. Coming to the bilateral parathyroid exploration. Bilateral parathyroid exploration, it is a standard technique in which all parathyroid glands are identified with exploration of the expected locations, and it's well demonstrated to exclude or identify the multi-gland disease with high surgical cure rates. That's 95 to 99%, as we are going to explore all of the parathyroid glands. A low threshold to either begin with or convert to bilateral parathyroid exploration is warranted in the following situations: when preoperative imaging studies fail to localize a single adenoma. Uh, in this, we should preclude a focused approach. And when the patients have a familial PHPT, such patients predictably have involvement of multiple glands. A bilateral parathyroid exploration should be considered for a young man with a apparent sporadic PHPT, as some of them may have undiagnosed Men's syndrome type 1. When concomitant thyroid disease requires a surgical resection, when the patient has a lithium associated hyperparathyroidism, lithium associated PHPT has a high chance of having multi gland involvement. However, if a preoperative imaging localizes to single adenoma and IUPTH monitoring is available, a focused approach may still be pursued. Surgical steps are similar to thyroidectomy, as already explained for the focused one. All four glands are exposed without disrupting the blood supply. Remove all the enlarged parathyroid glands and keeping a reasonable volume of viable parathyroid tissue to prevent permanent hypoparathyroidism. That is around 30 to 50 milligrams. Then this picture describes the right superior and the inferior parathyroid adenoma, and left superior and the inferior parathyroid adenoma. And this a total parathyroidectomy is done with the reimplantation into the brachioradialis muscle. Subtotal parathyroidectomy is done, and then the preservation is there, autotransplantation is there. And coming to the cryopreservation, this is a technique in which the parathyroid will be stored in a freezer. The gland is cut into the 1 mm cubic pieces and separated in the containers. Temperature which you are using in the cryopreservation, it is from 1 degree to minus 140 degrees Celsius, and risk of infection is there as the parathyroid is stored in a freezer along with the other samples. So persistent or recurrent PHPT. After initial parathyroidectomy, some patients develop persistent PHPT. That is the symptom less than 6 months from the initial exploration, or the recurrent one that is more than 6 months from the initial exploration. There is a disease. If the diagnosis of persistent or recurrent PHPT is suspected, it should be confirmed biochemically, and the indication for operation should be considered. It is generally recommended that two concordant images studies for localization should be obtained prior to re-exploration. Another valuable technique for localization prior to re-exploration for persistent or recurrent PHPT is the ultrasound guided FNAC with both histology and the parathyroid hormone assay performed on the aspirate. So FNACs also have the disadvantage. Due to the increased risk, and the indications for reoperation are more stringent than for the initial surgery, and the limited to major manifestations of hypercalcemia include nephrolithiasis, osteoporosis, serum calcium level more than 12, hypercalciuria, and 30% decrease in renin creatinine clearance. And we have a video assisted parathyroidectomy in which the patient recovery is faster, and an endoscopic parathyroidectomy cosmesis is better. Coming to the post-operative care, there is an expected drop in calcium, which can be treated by placing the patient on a calcium supplements, either oral or IV. Vitamin D level should be checked preoperatively, and the oral supplementation with the calcium is effective in treating post-operative hypocalcemia. Coming to the secondary hyperparathyroidism, use of calcium emetics. Gland excision is a standard with a parathyroid reimplantation, and approximately 30 to 50 milligram of parathyroid tissue should be reimplanted in the vascular bed. Then tertiary hyperparathyroidism. In this, there's a use of calcium emetics. Sinasalcid is the first available drug, which is FDA approved in 2004, and It acts as a calcium sensing receptor agonist, increasing the sensitivity of a receptor to the calcium, reduces the parathyroid hormone and calcium, and there is a leftward shift in the set point for calcium regulated PTH secretion after using this drug. And there is a sigmoidal curve which describes the relation between the calcium and the PTH. And coming to the last slide, parathyroid carcinoma, it is extremely rare, approximately 1%. High PTH level, high hypercalcemia, formed to hard fixed masses there, genetic mutations. There's a cyclin gene on chromosome number 13, red RB gene, and the P53 tumor suppressor genes are involved. Surgical management should be there. And compartmental resection, there's excision of parathyroid, thyroid in the central compartment node should be there and confirmed on a histopathology. Hence, intraoperative assessment is important. Thank you.
Thank you, Dr. Kanika. Well done, well covered. And remember, if you can palpate a parathyroid gland, the diagnosis is parathyroid carcinoma.
Yeah.
And think on those lines.
Yes, sir.
Adenomas, hyperplasias, they are not palpable.
Right, sir.
Any palpable nodule with hypercalcemia, think of this entity.
Yes, sir.
Hi, Dr. Deepak. Dr. Deepak Sareem, good morning.
Anji, good morning.
Sir, your comments.
So yeah, it's a vast topic. It really is. It is vast. It's something that initially was essentially the domain of general surgeons. With now, what we've seen that the trend is, and this is for all the trainees, is that a large number of these cases are being done by head and neck and ENT, especially in the Western world, and that trend will probably follow in India. So it's really important that we familiarize ourselves with this disease. It's a vast topic, and unlike other diseases we deal with, which are essentially anatomical problems, like there's a cancer, you need to remove it, there's a deviated septum, you need to straighten it, or there's a perforation in the eardrum and you need to fix it. This is a systemic biochemical disease. So it requires a different mindset to really understand the nuances of this. And you have to be a surgeon, but you have to be a physician if you want to deal with pathology. You cannot just be a technical surgeon who is inclined towards removal of abnormal glands. That's the first message I think I should give trainees. The second is the presentation. You know, in the West, the disease 90% of the time is picked up asymptomatic, only as a biochemical abnormality. Means an incidentally detected high calcium during blood work done for any medical condition is pursued. You see a concomitant high PTH and a diagnosis of PHPT is made. Our country still dominates with symptomatic presentation. They will come in with bone symptoms, bones and stones. These are the two key symptoms you'll see in this disease. So bones and skeletal and renal manifestations, these still predominate in our country because the disease is often overlooked. Dr. Diwan told you about the case with ankle pain, then abdominal pain for 3 years. We've seen patients with renal stones being removed 3 times. We've seen patients with fractures being fixed 5 times over 8 years, and a diagnosis of PHPT is overlooked. So essentially, the index of suspicion is low in the physician or surgeon community, and therefore this gets missed on initial presentations. But it will change. This will change as we get more automated blood serum chemistry analyzers. And as every time you order a KFT, if a routine calcium gets thrown into that report, very soon people with preclinical disease will be picked up because they have just high calciums. Just high calciums. And then you pursue it and you diagnose PHPD. I think one of the things what I would like to do is to see if there are any questions, but I am on a phone, not on a laptop today. I
No questions.
think there are no questions. Okay. So let me ask let me ask the presenter a couple of very basics, because you covered it very exhaustively, but it doesn't give to people who are not familiar with this disease an algorithm of how to manage. So I'm going to ask you a set of 4 or 5 questions just to give a clear picture to the listeners as to how manage. So Monica, what are the keystones for diagnosis of PHPT? What is essential to diagnose PHPT?
So it's a biochemical analysis in which we have a calcium and a PTH, and if it's asymptomatic. And in symptomatic also we have a calcium, we have a PTH, we have a calcium creatinine ratio. Uh,
So no, it's okay. We'll stop there. I think this message just needs to go out. A high calcium and a high PTH is PHPT. There are exceptions. You need to know the exceptions. But if you're seeing a combination of high calcium and high PTH, that's PHPT almost always. There are exceptions like tertiary hyperpara, like FHH, like lithium or diazide induced biochemical picture which matches. There are some exceptions, but the residents need to know, you see a high calcium, you see a high PTH, think PHP. Okay, next, once you've diagnosed somebody with this diagnosis, what is the essential workup you will order to confirm the diagnosis or assess the extent of disease? Just list the 4 or 5 tests you need to do.
in calcium,
A
PTH.
patient comes with high calcium and high PTH with a diagnosis of possible PHPT. What 4 or 5 tests do you order to confirm your diagnosis or assess the extent of damage of the disease on the body?
Ultrasound neck, systematic scan, DEXA bone densitometry, and then urinary calcium creatinine ratio.
Yeah, to that you can add, you might want to screen the kidney for stones also. So an ultrasound maybe. So essentially, your first two answers are not correct. You don't do an ultrasound or a sestamivi for diagnosis. They have no value in diagnosis. This is very important again for the residents to understand. The diagnosis is purely based on biochemistry, not on imaging. If you can't image an abnormal parathyroid, it does not change your diagnosis. Imaging is required only to decide what surgical procedure you will do on the patient. So, essentially, to diagnose it, you have high calcium, high PTH. Then, to assess the damage on the bones, you will generally do DEXA. For the kidneys, you will generally do an ultrasound to look for kidney stones or nephrocalcinosis. To rule out FHH, which is, I must say, very, very rare. It's very likely most of you will not see a single patient in your lifetime. But it is important to identify because surgery does not help these patients. So to rule out FHH, you need a urinary calcium creatinine ratio, which is very low. Essentially, with these three, you can assess the damage of the disease on the bones, stones, kidney, renal. I mean, kidney and skeletal. These are two common systems involved. There are lots of other things you do. Uh, I would say partly essential, partly not. For example, you can do a phosphorus, that will be low. You can do a vitamin D, which if it's low, you would like to correct it preoperatively. You want to make sure the calcium that you're seeing is a corrected calcium, so you need an albumin. If there are doubts, you can do an ionized calcium. So there's lots of other things, but I'm just trying to give you all a very basic workup pattern. So you've diagnosed it, you've assessed the disease, you've decided this patient needs surgery. There are some patients who can be observed with asymptomatic disease with no target organ damage. All others need surgery. Now you order the two localizing tests you said, which is sestamibi and ultrasound.
Ultrasonic.
If you fail to localize it on these, what would be the other tests you would generally order?
So
Because you gave a very, very long list of tests that can be done, but one needs to know what is generally ordered.
I'm going to order then the 4D CT scan and the choline, PET choline.
Yeah, I think I agree. These are the two most common second line testing used in the world, either a 4D CT or a choline PET. Okay. Now you have two situations. You have imaging where the gland is localized and you have imaging where the gland is not localized. What operation would you perform in either situations?
So, if there is a concordant imaging with the ultrasound and the system AB scan, and if there is a localization, then I'm going to approach through the focused gland approach. And if there is a discordant imaging, then I'm going to approach with the bilateral neck exploration.
Okay. So there are some questions that have come in. Maybe you want to tackle them.
Hello?
They are asking, is there first is for diagnosing parathyroid carcinoma preoperatively?
ठीक है.
Are there any criteria by which you can diagnose parathyroid carcinoma preoperatively?
Size criteria, PTH values, alkaline phosphatase for parathyroid carcinoma.
So for parathyroid carcinoma, I think the intraoperatively, we are going to assess it better as compared to the preoperatively.
When will you suspect parathyroid carcinoma? That is what the question.
The question is, can you suspect or diagnose it pre-op? And how do you
Preoperatively, on the clinical examination, we have a palpable nodule, and on a biochemical analysis, there is a high calcium level, very high calcium level for the this parathyroid carcinoma.
And intraoperatively?
Intraoperatively, there is a hard fixed mass which is present in the parathyroid, either it's superior or in the inferior one.
Yeah, I think essentially that's it. I would agree that there is no preoperative cutoff or definitive diagnosis, but classically parathyroid carcinoma will come with very, very high calciums, 13, 14, 15 or higher, a PTH that's generally in the thousands, and severely symptomatic. Like they don't present as mild disease. So that can raise an index of suspicion for parathyroid carcinoma, but there is no way to confirm it preoperatively. Because some people with even parathyroid adenomas can have a similar biochemical and clinical picture if they have severe disease. So you can only suspect it, but it's important to keep in mind when you see a severe presentation that this could be parathyroid carcinoma. Intraoperatively, the only thing you will find is the planes won't be very clean.
Yeah.
Most adenomas have beautiful planes. They shell out, they enucleate out easily. Atypical adenomas can sometimes have sticky planes, but parathyroid carcinomas invariably have sticky planes. But again, you cannot confirm it intraop, neither can you confirm it on a frozen section. So it's only clinical index of suspicion that can make you raise it. If you see it intraop, then the better thing is to extend the operation to include, for example, a hemithyroidectomy or a central compartment clearance on that side, in case the carcinoma is adherent to these structures. But that requires you to have consented the patient pre-op, which means you should have suspected it pre-op based on high PTH, high calcium, etc., etc. The other thing is, the other question is, what if it comes back post-operatively? I think then you have to think back at the surgery. If you think the resection was clean, it's fine. If you think it was adherent and it got peeled off the thyroid or central compartment, it may make sense to go back and do a secondary clearance. I think there is no unanimity on world literature what's the right way to do it. The role for post-op RT is also very, very debatable in parathyroid carcinoma. So essentially, you can only suspect it pre-op, you can suspect it intra-op, but the confirmation is histopath. But it's important to suspect because you should extend the operation if you feel there is doubt of parathyroid carcinoma. It's very difficult to go back and revise any surgical bed otherwise. So I think there is a mention of a size more than 4 and alk phos more than 300. Yeah, I think these are all criteria to start suspecting it, but there is no criteria that's an absolute cutoff for parathyroid carcinoma. We've seen adenomas 5 centimeter and larger very frequently. Not very frequently, but not uncommonly. Let me put it this way. So in the Western world, we must understand that classical adenomas are 8, 9 mm with a PTH of 100 and a calcium of 10, 10 and a half, 11. They see a very different disease than we do. So when they see a 4 centimeter adenoma with a PTH of 1000, calcium of 15, yes, their hit rate for calcium cancer will be very high in such a presentation. For us, it's very normal to see PTH of 500, 600, 700, adenomas 2, 3 centimeters in size and calciums of 13 in benign adenomas. So I think in our country, there is a lot of overlap in presentation between carcinoma and adenoma. which may not be so much in the
Happy
Western world,
birthday,
to see
ma'am.
very, very early asymptomatic disease.
आ रहे हो आज नहीं आ रहे
Um,
फिर आज तो ट्रीट है
so, Monica, there is a question. How to differentiate primary and tertiary hyperparathyroidism? Can you address that, please?
Yeah, in the primary one, there is a high level of the calcium, and the phosphorus is usually low or normal, while in the tertiary, both are high.
Yeah, that's a very, very important point. You can look at phosphorus. The other is you need a temporal association. Tertiary will typically happen in a patient with long standing CKD. And we're talking many years of CKD, creatinine fairly high, 3, 4. And sometimes it gets diagnosed because they get a transplant, but the PTH, which was high and thought to be secondary, does not drop after the transplant. So anyway, if you want to look at tertiary, you can look at phosphorus. That's a great clue. In CKD, what happens is the phosphorus goes up. And in fact, that's the stimulant for high PTH production, even more than the drop in calcium. And that's why you get secondary hyperparathyroidism in chronic kidney diseases from the high phosphorus levels. And these persist when they convert into tertiary. The other thing is time. You need time. In other words, you look at the patient's history and you find, yes, he had CKD for 5 years, 7 years, 10 years. During the time of CKD, his calcium was 8, 7, 6, 8.5. Classical CKD, low calcium, high PTH, the classical secondary hyperpara. And then you see the calcium trend has risen, and now the glands are autonomously hyperfunctioning and the calcium has gone up. So now they come with high PTH, high calcium, and that's when you call them tertiary. So a temporal association of the patient's calcium values will also help.
So well done, well covered. Many thanks, Dr. Sareen, for the valuable inputs. Thank you, Dr. Manika.
Thank you, sir.
Navneet, can we call it a day?
Thank you very much, trainees and faculty members, for joining the session.
Thank you
very much.